I'm from Selangor, if you all don't know, and besides the fact that we don't have a CM, we're also unfortunately famous for having lots of dengue deaths regularly, and so we had learned a lot of lessons in dengue mortality, and so just want to share a few of them. In the interest of time, I'll be brief. So I think in many of us, the dengue questions that we have in dengue whenever we see a patient will be, does this patient have dengue? If the patient has dengue, does the patient have high risk of getting severe dengue? And if the patient already has severe dengue, then the question is, when has the patient started leaking? And then the next question for us will be, what is the intravascular volume status? And if we think the intravascular volume status is poor, then what's the best fluid for the current regime? And then the next question is, when to suspect bleeding and when is recovery phase starting? And then Tanla has just added a question now, when is HLH starting in this patient? And so he has just got us these questions coming up. Okay, I'll just move on to, I think some of the challenges that we are facing currently in dengue mortality is we are starting to see patients leaking quite early in the disease. And patients are coming, and also patients, after all the alarm that we have created, patients are starting to come very early these days, and they're coming in the febrile phase. And we are not used to seeing patients in the febrile phase, and so we tend to start over-treating them because they become tachycardic in the febrile phase, and we treat them. We are also starting to see patients bleeding and leaking at the same time. And so the hematocrits are normal, and that's something that we need to work on. And organ failures are becoming more common in the years to come. Okay. With the first question regarding patients coming in early, so patients coming in with only a history of fever. We have had a few cases where we missed patients who are coming in with currently no fever, but there's been a history of fever in the past, and then we missed the whole diagnosis of dengue until it's too late. And so remember, in dengue triaging, it is not current fever, it's history of fever, because by the time they reach us, they could be afebrile. So in dengue triaging, it's the history of fever. We still miss, even yesterday we had a discussion, we still miss a few patients in our emergency department when they are still in compensated shock. So when they're in compensated shock, they're otherwise well, they're just tachycardic. And but we miss them because and that's a time where the intervention is best given when they're in compensated shock. When they're in decompensated shock, it's a bit too late to treat, and so we are still missing patients in the emergency department because of compensated shock. Yesterday, I remember Venu was making a comment. We are scared to use the word shock in someone who is alert, conscious, and talking to us, and I think we should go away from that and use the word compensated shock as, don't just look at the overall condition. Many of us, right, the patient looks stable. And so even though the pulse rate is high, the hematocrit is high, we don't want to use the term compensated shock. So give importance to the vital signs and believe it. And we have had occasions where in emergency department, blood pressure is taken repeatedly until it becomes a reasonably nice number, and then we stop. Because I've had one patient, we had 4 times blood pressure taken repeatedly just to get that number, nice number, so then we say, then fine, then we are fine. And so please believe the vital signs and then treat them accordingly. Okay, I talked to you about I've talked to you about the compensated shock. Compensated shock patients are usually clear consciousness. They can still joke with you, and doesn't mean they are not in shock. And I'm sure Prof. Lusla mentioned regarding you have to put a finger on the patient to get the diagnosis of shock. The other questions regarding patients who are coming in early in the febrile phase. So we are struggling with patients coming in early in the febrile phase, and so when they come in early in the febrile phase, they're tachycardic, and sometimes they have a high hematocrit, sometimes purely because of dehydration. So we start thinking that these patients are in shock, or we start thinking that these patients are leaking, and we start over treating them. And then what happens, the leaking phase actually starts a bit later down the track. And then of course by then we are winding down already. And so remember not to over treat patients in febrile phase, and if they can take orally well, it's called masterly inactivity and cat-like observation, and so you just have to keep quiet and watch them closely. The tricky part is actually bleed and leak at the same time. We are starting to see patients. The last case that we had, very bad case that we had, was someone who had managed in a private hospital. The hematocrit was creeping up the whole night, throughout the night, from baseline of 39 to 42, 44, 46, and hematocrit was 46 when they called us, and the platelet count, of course, was double digits. And the patient was transfused platelets, but the hematocrit was and so we thought that kind of acidosis, the lactates are around 7 or 8, that kind of a condition cannot be purely leaking. And so we asked them to give gelafundin and send the patient over to us. And in our emergency department, we had emergency O on standby. Patient came in, true enough, after the first 1 pint of gelafundin that was run, the hematocrit from 46 was down to 39. Patient was still in shock. So we were able to unmask the bleeding with a gelafundin infusion and then start giving the blood as soon as possible. So we are starting to see patients at the peak of their leaking. So the hematocrit is going up and they are bleeding at the same time. And this is happening. Maybe it's because a lot more liver disease we are seeing now, liver disinfection seeing now, maybe because of that. So we are starting to see a lot more patients bleeding and leaking at the same time. And that's why we tend to tell now that if the hematocrit is going up, this hematocrit is high, and despite crystalloids, hematocrit is persistently high, our suggestion is to try colloids. And our colloids seems to bring down the hematocrit well and unmask the bleed. And so we can see the bleed better. And so that's the reason why we are starting to use a lot more colloids in patients who've got high hematocrits if the crystalloids don't work. Okay. So remember the patients at risk of major bleeding. I think you've gone through this. I've gone through this, isn't it, earlier? Gone through this, so I won't repeat that. Okay. Just last thing about how fresh is fresh. I think at least in Slango, there has been a consensus that all the major hospitals will keep bloods of less than a week old of all blood groups. Dengue, the Slango, all the hospitals have agreed to do that, and so we'll have to make sure. So many times, what happens? We order blood, and then the blood comes up. And you see it's a 3-week-old blood, and it's happened to us before. And so when we give old blood, what happens is they don't have enough 2,3 DPG, and so they don't let go of the oxygen when they reach the cells. And so you don't really, the red cells just improve the number, but it doesn't improve anything else. And so we have to make sure our red cells that we get, or the fresh whole blood that we get, is really fresh. And we take consensus that it's less than a week old. And if it's less than a week old, that's what we should expect all our blood banks to keep. Okay, and remember there is a role for emergency O blood in situations where patients comes into your emergency department with bleeding and hypotension, or low hematocrit and hypotension in a dengue patient. So you'll have to think of bleeding, and so don't hesitate to use emergency O blood. And there's something called first stage cross match. A first stage cross match takes 20 minutes, while the traditional cross match takes 40 minutes. And so you send a houseman over. So housemen are useful sometimes. So you send the houseman over ask them to wait for 20 minutes and get the blood back, and that's what we did for these patients. So emergency, remember the words of first stage cross match and emergency O, and it's life-saving some situations. Okay. Last thing is regarding organ failures. When the organ failures, the problem with organ failures is, especially the liver diseases, when a liver, our idea of recovery phase. Our recovery phase is, evidence of cessation of plasma leakage, blood pressure is becoming stable, the hematocrit decreases to a proper value, decreases, and there is good pulse volume, patient becomes afebrile, and patient resolves bowel and abdominal symptoms and improving urine output. This is our sort of status that we say is recovery phase. But somebody has liver disease, liver impairment, it's very difficult to pick up recovery phase. And sometimes what happens is we don't know when to switch off. So we don't know when to switch off, and our traditional method of switching off the resuscitation is to stop. See the patient is getting better, his appetite is improving, or his nausea is less, and so then we stop. But in a patient who's got liver impairment, all that doesn't happen, and so we have a problem of resuscitating patients very well and not stopping resuscitation, and that's been our big problem now. And so we have to learn to say this we have to pick up when the leakage phase started, keep counting the 48 hours and realize that very likely the leakage phase is stopping, and stop continuing to resuscitate patients. Stop giving more blood, stop giving more FFP, stop giving more fluids. And so that's our big problem sometimes, and we are really ending up overload because we don't know when to stop. Okay. The last thing the other things that these are other things that I mentioned earlier itself. Early aggressive fluid resuscitation. So the previous years, what has happened is many of our deaths in dengue has been fluid overload deaths. They were huge positive balances, 10-liter positive balances. Your lung will be all wiped out. There'll be tense ascites, and that's how many of our deaths happen. And so then we moved on towards conservative fluid regimes to prevent that. And in the way of doing conservative fluid regimes, what we did was when patients arrived in an emergency department in shock or in compensated shock, we tend to be conservative. And now we are saying when someone comes in very ill in emergency, comes in with compensated shock in emergency department, we need to start aggressive fluid regimes and taper down rapidly, not start low and then go up. We need to be aggressive begin to start with and then step down. And the idea is, let's say you start with a 10 and then you come down to 7, come down to 5, come down to 3, 2, something like that. Not start with a 2 and then go up to 3, go up to 5 and then go up to not respond, go to 7. So start high regimes when someone's compensated shock and then step down rapidly, and that's important. Correct hyperglycemias aggressively, and so we shouldn't look at our sepsis guidelines and say permissive for hyperglycemias. So we need to correct them aggressively. And when we give a lot of normal saline drips, people get normal anion gap acidosis. There is hyperchloremic acidosis, and so hyperchloremic acidosis itself is not something. This shouldn't make us resuscitate them more often. So whenever we see a patient acidotic, you need to look at the anion gap. If it is normal anion gap acidosis, you need to say that's because of too much normal saline drip. You could switch to drips that have got low chloride, or you could cut down your drip if it's otherwise warranted. The fourth problem that we are seeing, at least this season of dengue in Sungai at least, we are starting to see a lot of patients myocardial depression. So these are, I'll give you an example of a classical patient who comes in myocardial depression. These are patients, young females that we have seen so far, and young females comes to us with tachycardia. So they do have cold, clammy skin that makes us worried, and then we of course when you have a cold, clammy skin and tachycardic, of course we look at the hematocrit. Hematocrit does not budge, doesn't go up, doesn't go down as what do you see, a leaking patient or bleeding patient. Hematocrit remains normal. And so when hematocrit remains normal and patient is tachycardic, our response is it's the bleed. And then we start giving them lots of blood and stuff like that. But on the other contrary, we believe that and send them to the intensive care units, and we put an intra-arterial monitoring blood pressures. The blood pressures are normal. The blood pressures are normal while doing intra-arterial monitoring, but they have cold, clammy skins. Their hematocrit doesn't budge. And these are the patients, I think, are patients with myocardial depression, and we do echocardiogram, the EF, the myocardial function is poor. And so there will be some patients who have got coming in with myocarditis and myocardial depression. And the way to pick them up will be tachycardic, but hematocrit is not moving in either direction, as we expect from a bleeding patient or a patient who's got plasma leakage. And such patients have to end up in, and their lactate levels don't go up. Lactate levels are not high. They're not acidotic otherwise. So such patients, and our protocol currently is they end up in ICU. We bring them into intensive care units so that we don't over-treat them. So otherwise, we'll tend to over-treat them. We give lots of fluids, or we give them blood, and we mess up the situation. And so we bring them into intensive care units. We monitor the arterial blood pressure using intra-arterial monitoring, invasive blood monitoring. And then we observe them in ICUs, and some patients do get low-dose inotropes to manage myocardial depression. Okay, and we are trying to convince UITM colleagues to do our UITM colleagues to do a more proper cardiac assessment of all these patients to document the situation of myocardial depression. I think I was. And if you have to ask me what is the single most important intervention that anybody can do if their hospitals dengue mortality is monitoring, is mounting, is to have a separate dengue team. So whenever our rates go up, we'll have a separate set of doctors managing nothing but dengue, and I think that is instrumental in bringing down dengue mortality, because one team looks at nothing but dengue, and we start making less mistakes. And I think this is the single most important lesson that learned dengue mortality. Okay, and of course, I think this book will be a must read, and especially I think one or two authors are here sitting in the front, and if you don't have time, at least read this part on pitfalls in the management of dengue and solutions. And I think this is something that you guys have to read if you are managing dengue patients. I think I'll stop here. Thanks.